Let me ask Betty, you now. You did a great discussion at ASCO GU after the NIAGARA data and the segment 274. I know you have led trials with dose dense and MVAC. What's your take in that data set? How do you synthesize the NIAGARA data in your practice? Do you see a role for dose dense and MVAC plus checkpoint inhibition? There's some phase 2 trials looking at that. How do you practice going forward?
Thanks for that question. Um, Niagara was really interesting. I think it's a great idea. It's the first of 6 sandwich design trials that we're about to see in bladder. They all have a GemCis control arm. Many that are chemo combos have the GemCis backbone. So, I guess I was hoping that it would bump that bar up higher in terms of event-free survival and overall survival, and we might see better long-term outcomes in the long run as we follow this. But so far, I guess I just wasn't as impressed with the delta there at the expense, as Chris mentioned, of really treating everybody with adjuvant. So 8 cycles of adjuvant afterwards for everybody. So there's not sort of an allocation based on stage or risk or prognostic factors the way there is in 274. It's built in. It's an adjuvant trial. It can do that. So those were the 2 main considerations. You asked about dose dense MVAC. I mean, I do think, the data that we generate with trials of generic chemotherapies that everyone's sick of hearing about, it's harder. It's harder. We can't do pharma-backed trials that reimburse. We can't do the data cleaning and the querying in the same way. But hats off to Coxon and Vesper. They did do 2 randomized trials. The results were very consistent across those 2 trials, which is very consistent with some of the phase 2 single arm data. So I think we do have a good sense of how dose dense MVAC performs and how it performs relative to GemCis. And then we sort of take that and say, well, okay, it's a little better. Some people aren't comfortable giving it, but a lot of people are. Could we combine that with immunotherapy? And unfortunately, we have all this data on GemCis immunotherapy, right? And very little on dose dense MVAC immunotherapy. But the little bit we have, I think, is pretty compelling. So we have RETAIN-2, which we presented, which combined dose dense MVAC with 3 cycles of nivolumab with a bladder preservation approach, similar to Matt's HCRN study, similar to RETAIN-1. And we were really pleasantly surprised with the pathologic complete responses we got in the patients we expected to have disease in their bladder. 40% didn't. And also the EFS of 84%, which is sort of better than we've seen. So again, I think we're going to have to explore this in investigator-initiated cooperative group work. There's just no other way. But if it's better, I think we should at least pursue it and be asking those questions.
Thanks, Betsy, and kudos for the RETAIN-2 trial that Dr. Gadalla presented at ASCO GU, and thanks for stopping to our poster for the dose dense MVAC Pembro trial we did for variant histologists here at UW for HADS with PathCR approaching 60%, again, raising this hypothesis. And I think there was the AURA trial in Europe looking at
That's
dose
right.
dense MVAC avelumab.
Yeah.
It's interesting discussion. Guru, let me ask you next. What's your practice going forward? Do you anticipate durvalumab to be approved and in the neoadjuvant-adjuvant setting, and how would you use it if that's the case?
Yes, I would expect durvalumab combined with gemcitabine cisplatin to be approved. I think that the case for gemcis durvalumab and all comers is that there was improvement in EFS and OS, and there was early separation in EFS. So separation did not start like after cystectomy, seemed to be starting even before. That would argue for a benefit to a larger group of patients. However, the counter argument is that patients who have a pathCR with GemCis or dose dense MVAC, they don't potentially need anything, right? They have good outcomes. And so if we just knew who those patients were, we could offer those patients just GemCis and get away with no immune checkpoint inhibitor pre or post if they achieve pathCR. I think that is not a great biomarker we have. I know that the DNA damage repair alterations have been looked at in your bladder-sparing trials. I think that ERCC2 is the only one I see that looks more impressive than the other alterations across different studies. But I think that more work needs to be done to develop precision medicine now so that we can give patients the right treatment and not over-treat patients.
For sure, great points. And of course, over-treatment is a big concern, toxicity cost, and of course, how to avoid under-treatment as well. Matt, in that discussion context, you saw the data from NIAGARA updates at ASCO GU, looking at the breakdown of patients with and without pathologic complete response. And the data were very interesting in terms of the role of durvalumab in those subsets. Could you comment a little bit on those data sets that you presented, and what's your, let's say, interpretation of these exploratory analysis results?
Sure. So exploratory analysis, like you point out, looking at the impact of path CR or non-path CR on outcomes stratified by treatment arm, looking at endpoints of both EFS and OS. So the top line is that if you have a path CR and you're assigned to the durvalumab arm, your event-free survival is better than if you're assigned to the control arm. Similarly, if you don't have a path CR, your event-free survival is better if you're assigned to the durvalumab arm. So I think there's two take-home messages there. I mean, we could, it's an exploratory analysis. We can argue about the size of the effect, but I guess I would push back a little bit on this concept that if you get a path CR, you're fine. If you asked most of us what the risk of recurrence is, metastatic recurrence in a patient with path CR, most people throw out the number 10%. So I don't know if that's fine for all of our patients. That's not insignificant. So I think we can do better even for those patients. And there's a signal that perhaps with immune checkpoint blockade, the quality of the response, not only the quantity, but the quality of the response might be different. That's not too surprising. We see that in the metastatic setting as well. I think the non-path CR effect is quite interesting as well, because it finally, in my mind, puts to bed a little bit this concept that you have to have a path CR with neoadjuvant therapy to benefit from treatment. I think as medical oncologists, we never sort of bought into that. We all have patients who have big, bulky tumors, hydronephrosis. You give them neoadjuvant chemotherapy, their tumor shrinks. It's still there, but it shrinks. Those patients get surgery, they never have evidence of recurrence. You have to feel that in a subset of our patients, there's eradication of micrometastatic disease, but not full eradication of the primary tumor, and they probably benefit from the systemic treatment. So I think that non-path CR analysis really drives that home, because in the past, we didn't have two different systemic therapy regimens to make that assessment. It was just surgery versus neoadjuvant chemotherapy, but now we can tease that out a little bit. So I thought that was interesting and I think informative big picture wise in terms of what we're potentially accomplishing with neoadjuvant treatment.
Excellent. Thanks, Matt, for this very detailed explanation. And, you raised some really interesting points there.